Hey, GLP1 plus size community. Before we jump into the podcast, please take the time to leave us a 5-star review on whatever audio platform you're listening to the podcast on. Share your story and how the podcast has helped you. This will help us get referred up in the audio platform so that we can reach more people that need our help, our support, and guidance from our doctors. Help us get loud and change things.
20 seconds a week to lose 20% of your weight in a year with diet and exercise. That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Dr. Jennah Siwak.
Right? Hi.
Did I say it right?
Siwak. It's a hard one.
Oh, you said Siwak. I said
Siwak.
And I was telling him the whole time. It's like
you were really practicing. I'm trying to make the motions like whack.
Siwak.
There you go. Or Jennah is okay.
I could have sworn it was okay. Wow.
It's okay. We're close and we corrected it. This is the scrappiest podcast in the land.
It is. It's
good. I was wrong. I was loud and wrong.
Well, Jennah,
thanks for having me. Thanks for pulling me out of my shell and making me be here.
Yes. We're so glad. You. We love your videos and they're so informational, and you're such a great advocate for us that struggle with obesity, that struggle with, type 2 diabetes, that struggle with PCOS. Like, you understand like how these things are all connected and how metabolically this matters, for our health and for our lives. So I'm so glad that you were able to come on and talk with us today.
Yeah.
And we were able to have Mary here. Mary, feel free, of course, to join in the conversation. This is meant to be an educational and advocacy podcast. So we would love to have any kind of interjections you may have. Of course, we have given you questions ahead of time. So anybody that wants to come on in the future, it's a warm seat, not a hot seat. So, but if you could tell us a little bit about you and why you're here and what you focus on, then we can go from there.
Okay, well, I'm a mom to 3 kids, 1, 3, and 4. I always feel like I have to start with that. And then I'm also a physician. So I'm a family doctor first and foremost. I'm also double board certified in obesity medicine. I practice full-time family medicine, and I incorporate obesity medicine into my practice. So that's kind of how that's the balance that I figured out works for me.
Yeah.
And I really enjoy it. So I feel so strongly about it because obesity medicine and treating obesity is at the core of almost everything, not almost everything, but so much of the chronic diseases that we manage in primary care. It just doesn't make sense not to treat it. So that's why it matters so much to me.
Yeah. I think that's awesome. I mean, I started my care with a primary care doctor, and they've been taking care of me. I've gotten to the point where I want someone that specializes in obesity to oversee me, because I recognize now, learning through this process, that it is something I'm always going to struggle with. And so I wanted like that specialty, but I think it's wonderful because there aren't enough obesity specialists. So being able to, from a primary care perspective, be able to like tap into that is huge. And I hope more people know, like, you can go to a regular doctor. And if that one doesn't work, then you can look for telehealth obesity practices and things like that too.
I do. There's so few primary cares who are board certified in obesity medicine. You can be any type of physician and be board certified. So that's really the tricky part, is we can give people the resources, like, go look here, but that could be an anesthesiologist who's board certified, or a lot are endocrinologists, some are pediatricians. So I do think it's hard to find a primary care. There's one other PCP in my area. Of somebody who has that background, who's using it. So I know I even hesitate to tell people to go look for a primary care who has that board certification, because it's so hard to find. And I think a lot of people will need to use telehealth, but I know you've talked about how your primary care manages your Mounjaro, right?
Ozempic for me.
Ozempic.
I came too late to the Mounjaro party. When I came,
I didn't know that.
No, I started on Saxenda.
Okay.
And then I did that for a while, and then insurance had me switch, and now I'm on Ozempic, and I'll probably cut that out soon, to be honest. But it's going really well. But so that's when and then maybe Mounjaro will come around for obesity, and things will be different. But yeah, obviously not a lot of insurance covers that yet. But
But I
speaking
do think
of,
a lot of PCPs, even who are willing to manage it, don't necessarily know how to adjust it or don't know how to keep the frequent contact or aren't willing to do the PA. So yeah, it's a huge struggle. But I feel like obesity medicine should be something that is worked into a primary care residency program, and it could be, but it should just be part of the core training for that, and maybe one day it will be. It would just make sense. But yeah, right now
I hope so.
Yeah.
We've definitely learned lately that it's and from several people that it's like, it's unless you choose to go back or set aside to get certified in those areas, like it's not something that's readily taught.
It's not at all. No.
Yeah. So I think that's why it seems like that's a lot of the reason why that like we see a lot of doctors that don't really know much about it. Like we had I don't know if you know Bourbon RX, but he came on, he was like, like they told us, like literally the focus was, if you are obese, you're going to have a heart attack or get type 2 diabetes. Stop it, eat less, move more. And that's what we've all been saying forever. Like, and so we're like, maybe there's another way. Like there's science and data to back this up, But speaking of all these GLP-1s, there may be some people that don't know what these actually mean or how these actually work.
I don't think a lot of physicians even do. And I do think that's a big part of that. I mean, yes, obesity, stigma, weight bias, I think that's a big part of it, but also they have not learned. And so I really do think we're going to start to see that change. So I'm 5 years out of residency. And when I was in residency, the big GLP was Trulicity. It was once a week, and that was the big one. And so I got out of residency and I was using that. And then I realized the endocrinologists were prescribing Ozempic. And I was like, ooh, what's that? And that became the big one. So it's just when you think about how new the ones that we utilize for weight management are, it's still really new. So it kind of makes sense. But even in like a typical primary care residency program, it's still not all PCPs are even going to be comfortable using those for diabetes management. So and I think the weight management piece, they're definitely not comfortable with that. Not the average PCP, unfortunately. So I do think it's going to change drastically in the next 10 years or so. And I'm really excited to be part of that.
I think the common misconception that I'm hearing for people that like will comment on my posts or videos or whatever, they'll say, oh, okay, so it's just an appetite suppressant. And I feel like it works very differently in the body. And you have described that in some of your videos. Could you kind of just give us like a rundown of what that looks like for people maybe who don't know that are listening?
So I always tell people there's a couple of different ways that the GLP-1 medications work. They do work by increasing satiety. They slow down gastric emptying so that the food is just moving through your body slower, so you get fuller quicker and you're less hungry. But they also work on the insulin resistance portion, so they affect the insulin and the glucagon release and help your body regulate blood sugar. So I still would say that the main way that these medications work is by making you feel fuller quicker, but they're not an appetite suppressant like what we typically think of, like phentermine. They're not a stimulant. Totally different than that. And they work on that insulin resistance component, which is really important for people with PCOS or prediabetes or diabetes type 2 or any degree of insulin resistance, which we know there's a whole spectrum. So
that's very cool. Thank you.
Her most recent video where she talked about Ozempic, it was just so out there. It was all over the place. But the biggest thing that she said, I think that irked a lot of people, was that, of course, it's a shortcut. Talking about surgery or meds or pretty much everything. Well, of course, it's a shortcut. No, it's not a shortcut. We know that obesity management is typically a long-term, lifelong thing. So, and there's a lot that goes into it depending on what route you go as far as medications or surgery. And it is not a shortcut.
Speaking of anxiety, we mentioned that earlier. Mary even mentioned that she was struggling with some anxiety. And I mentioned that like, even with me, with the food noise was kind of all the noise was gone for me. It wasn't just the food noise, And so like all my anxiety kind of just like, just turned right off. It was kind of incredible. But Kat had mentioned about
how's
like
that work?
addiction, right, Kat?
Addiction. Yeah. It doesn't, I've heard some stories where people say like their cravings for smoking, alcohol have also quieted, not only just the anxiety and the food noise and the white knuckling, but a lot of that has also subsided as well after taking a GLP-1. Or
there is science to support that. I know that's like a heavily researched area currently, but there are GLP receptors in the brain and the reward center and in our center of the brain that regulates emotions and mood. So it is definitely possible. I almost hate admitting that right now, because then the Bethany Frankel thing that we're personality changes, right? But that's not what we're talking about. But yeah, there is science to support just with the GLP receptors in the brain. The other piece that I do think plays a big role is it depends on what your anxiety is about. And I know you mentioned it's not more than just the food noise and the food chatter, but for a lot of people, they do have anxiety around what they're eating, especially with binge eating disorders. And health anxiety. So if a lot of their health conditions are improving and they no longer have that food noise, and that food noise is just gone, their anxiety is going to improve too, because the source of that anxiety is gone. So it could be a combination of it's probably both of those, but we don't know a definite mechanism by which it would improve anxiety yet. Like if we look at a lot of our anxiety depression meds, we know, okay, it works on the serotonin or the norepinephrine and dopamine. And there's theories that it's doing similar things, but we don't know that much detail about it yet. But I think more will come out, and that's a common thing I hear from my patients too, that their anxiety is improved. And it's really, really interesting. I have not had any patients who've quit smoking. I've like secretly hoped a couple would quit smoking on it, and that hasn't happened. So kind of disappointed in that, but so I haven't seen that too much, but I know some people do say that it helps. Yeah.
And I've heard other people say sometimes that it doesn't, that it goes the other way and causes more anxiety. And then I know there were some studies that kind of talked about the difference between like anxiety and then like depression, and like, you know, how those were kind of looked at in different ways. It was more of like improvement with anxiety as opposed to improvement with depression. I was thinking I saw one of your videos about that.
I don't think that was me.
Was it yours?
But it'd still be similar, and I would say it's probably going to be a similar mechanism. It still all stems from that same area of the brain. So I think there'll be more to come on that, and I'm super excited.
I'm excited to see how it goes too.
Food has definitely been a very dominant voice in my head. That's not the main focus anymore. Dieting, exercising, and adding GLP-1s through Ro is a game changer. I have such a sense of mental freedom since I started with Ro. Food no longer controls my thoughts. Family time used to revolve around food, and now it revolves around what we're gonna go do together.
This one is kind of a warm topic.
Oh, okay. Go for it.
well, only because we have so many new members to the GLP-1 community. And I find that so many of them, and I think all of us can attest to this, that they're very apprehensive, if not scared, of the side effects of these medications. And, you know, I know that I openly talk about mine only to be transparent, but they're like, I want to start, but I'm really afraid of the side effects. And I know, as probably as a doctor, you know, hear this also, but my question is, can you talk to us about the side effects? And also, are the side effects usually manageable? So, you know, just to kind of educate people on this.
So I think it is important for people to be aware that there are common side effects that get better with time, that are kind of expected because of how the medication works. And so that's always a big discussion that I'll have. People do have to know about the potential side effects. So just with the way that the medication works, with it slowing down gastric emptying, a lot of the side effects are going to go along with that, and they're going to be gastrointestinal related. So I tell people they should expect, to some degree, mild, manageable side effects, at least with starting the medication. That should improve with time. It should be tolerable. If it's not tolerable, then it's not the right medication, or it's not the right dose, because it shouldn't be severe. But nausea, heartburn because the food is not leaving your stomach as quickly. So if people eat like close to bed, or even when they normally would eat, that food could still be in their stomach. So they might find that they have to adjust. They can't eat as close to bed. They can't eat certain things that are going to trigger heartburn. They have to eat smaller meals, but people usually will adjust. So heartburn is a big one. Nausea. And nausea usually is the first 2-3 days after an injection, and gets better and does usually improve with time. And we can also make that tolerable by having like Zofran on hand is appropriate for most patients. So I will usually offer that when I am starting a medication, and I think it's totally fine to have that on hand. as long as it's not needed like 4 times a day forever and ever. And then constipation is the biggest thing that I see. And I think it's really important for people to stay on top of that. So some people will ignore the constipation until it gets to the point that they're having, bleeding hemorrhoids. And we're like, okay, now what are we going to do?
Yeah.
People kind of expect it, they'll know like, okay, I need to start Miralax, I need to start magnesium. And there's a lot of different remedies for that work for different people. So like magnesium citrate, and none of this is medical advice, by the way. I'm just going to throw that out here. General
disclaimer.
Should have done that in the beginning, but yes, all this is educational purposes only. But magnesium citrate can be really good for constipation, especially for people who just aren't going to do powders, because a lot of people just aren't going to do powders. But otherwise, Miralax is great. Fiber is great. I think the little Miralax fiber cocktail is great. I think a lot of people on here do that. But there's a lot of ways. The point being, there's so many different ways that we can manage constipation. And that is the number one side effect that I've seen with Mounjaro is constipation. But it has not been so severe that anybody has quit Mounjaro. So those would all be common. Less common would be like profuse vomiting. And if that's the case, that if someone on TikTok is talking about that, often that's going to be someone who was put on too high of a dose, so that's more like a doctor error. But it may not be, but profuse vomiting would not be a common side effect. And then the ones that people are typically scared of are pancreatitis, which is not at all a common side effect that we see with GLP meds. It's a common side effect that we see with diabetes and inflamed, angry pancreases. And thyroid cancer is the big one, which there's no good conclusive evidence that these medications cause thyroid cancer unless you're a rat. So as long as people don't have that specific family history or personal history of that medullary thyroid carcinoma or MEN2 syndrome. Medullary thyroid carcinoma is usually genetic as part of MEN2 syndrome, and it's very, very rare. I've still never had a patient who had a family history of medullary thyroid carcinoma. It's that rare. So we usually see papillary thyroid cancer, follicular, some other type. It's rarely medullary thyroid carcinoma. So that's the only true contraindication to these meds, is that particular history or family history because of the rodent studies. So
I do know some rats that masquerade.
If you're related to rats. And that's not to say, like, I don't think we can 100% say, like, okay, this is never going to be an issue. It's just that it's really hard for the studies to make that determination because it's such a rare thing anyway. And we have 20 years of data, so they're not brand new, but we don't have 50 years of data. So, is it possible that 20 or 30 years from now, they might say, okay, yes, there's absolutely a small increased risk. I think that's a possibility, but I don't think it's going to be a large risk. And there is a risk of thyroid cancer anyway that is related to obesity. So it's always going to be risk versus benefits, and what are the risk of going untreated? What are the risk of untreated obesity and diabetes? And there's like 12, 13 different cancers that are associated with obesity. So we always have to weigh the risk and the benefits, but for most people, the benefits will outweigh the risk.
Okay. And I'm so glad you said that, because that's what I that's what I say, is that the benefit definitely is more than the risk. And another side effect that we're hearing more about is hair loss. And we're seeing it in the media also, of these drugs cause hair loss. And I thought it was rapid weight loss will cause hair loss, not necessarily these medications. Can you explain that and briefly discuss that so we're more educated on it?
Yeah. And as far as I'm aware, I don't believe there is a mechanism by which the medication causes hair loss, at least not that we know of. So we think that's more just related to the stress of, it could be the stress of a new medication on the body. It could be from the stress of the weight loss. And personally, I've not had patients experience hair loss that haven't had a pretty significant weight loss. But we can experience hair loss after any big stress. So it's the same type of hair loss that we see after as a mom, after we give birth. It's 3 to 4 months later we start losing hair, and that can go on for several months, and then it stops, and it feels like it's never going to stop, and you feel like you're going bald. And I feel like I've been there constantly the past few years.
I bet.
I bet.
It comes back, and it usually does.
I guess so.
Does come back. Yeah. So so that can definitely happen, but we think that is more related to the rapid or significant weight loss, maybe due to some nutritional deficiencies, which is definitely a possibility. So not getting enough protein, not getting iron, not getting vitamin D. So having those levels checked, like an iron level and a ferritin level, not just blood counts, would be one good thing to do. So thyroid levels, for people who are prone to that. So I still think it deserves a workup, just like anything else, but it's not an unexpected thing. And we don't think it's because of the medication right now. We think it's from just the lack of nutrients, maybe a deficiency, or just the rapid weight loss and the shock to the body.
Gotcha. And then it usually grows back, you said,
it almost always grows back. So if that were to go on for so long, like say somebody is in a constant state of severe stress can cause that type of hair loss. If you never get out of that stress, then maybe it could be a more permanent thing. If you're in a chronic state for many years of iron deficiency, then maybe those hair follicles aren't going to start regenerating. But typically it will reverse. Like, so the idea with the weight loss would be when the rapid weight loss, or once you reach maintenance, we would hope things would level out. I don't think we've got any good studies on that right now, but I'm very hopeful that hair would come back. But I know it's a big worry for a lot of people. It's a hard one.
GLP-1 community is we're now empowered because of doctors like you.
Yeah.
Thank you. And being advocates for ourselves. But our GLP-1 community that's listening, how can they leverage the medications that treat obesity and work with our physicians to find a maintenance dose to kind of live happily ever after? Or essentially, how do we work with our physicians to find that dose, that sweet spot?
Is it more with how do you convince your physicians that you need to?
Yes,
definitely.
Let's put it that way. How do we approach that sensitive topic? Because a lot of doctors will say, it's time for you to get off of it. How do we approach that? Or
that is a really hard one. I'm trying to think of how we would convince them. So I know, like, I have a lot of physicians who follow me, and I think that's one of the best ways we can teach them. Like, I'm always paying attention to the new things that people are saying about hormonal therapy. Even on TikTok, that's one of the ways we learn. So when you see other health providers, if you trust their opinion and they're saying, hey, like, we need maintenance dosing, I think that's really big. I think it's harder for patients to convince physicians of that. Other than, say, bringing in articles or bringing in something where you think they're going to respect the opinion. I don't even know what kind of article that would be, because probably bringing in TikTok videos is not going to have a lot of sway with your physician. But I do think bringing in data, bringing in articles by like someone who's board certified in obesity medicine that is saying like, hey, we need maintenance dosing and here's why. I think that would be helpful. Because sometimes if they just don't know, they're going to be happy to have some sort of a guideline. And that's the hard part, because there aren't real guidelines. There's just opinions right now. But I think that's going to be another thing that will change, but it could be very hard to convince a physician who's not ready to hear that, or who does not believe in that. Because the issue is a lot more than just what their opinion is on maintenance dosing. It's probably, when and how they would treat obesity with medications anyway. And so a lot of that just goes back to that basic understanding of we need to treat obesity like any other chronic disease. But I think always appealing to them, like, this is helping me manage these multiple other things, always going back to your comorbidities and the logical side of what else it's doing for you is really important. And I would just say something like, most experts in the field believe there should be maintenance dosing, and I would try to show some sort of proof about that. I've had a lot of patients for other things that will send me, articles and and things they want to try. I'm like, oh, that makes sense. Okay. But it's because they sent me an article, and that's, we're driven by data. And I think that's always going to be really important when you're talking to your doctor, if they're not on board.
In your experience, if a diabetic patient has not met their weight loss goal, but their A1C is below 6, do you still titrate that patient up to meet the weight loss goal? Or since the A1C is now below 6, do you
So I have a lot of patients that I'm using GLPs like Mounjaro just for weight or for obesity treatment, some for type 2 diabetes and some for both. But yeah, you can titrate up to either one of those goals. We know that Mounjaro by itself without other types of medications like insulin that cause low blood sugars, it's not going to cause low blood sugar. So you would titrate up until we're seeing the weight loss result that we want, as long as people are tolerating it. And not that it's all about the medication, but until we're seeing the appetite reduction that's helping get rid of the food noise, and the medication is well tolerated, and they still have an appetite to the point that they can take in the nutrients that they need. So I will titrate up to the appropriate dose from a weight perspective. Yeah, I will. But there's not a lot of guidance on that, and so that's the thing. It's just it depends on what your physician thinks. But so that would be no different than like in the case of somebody who has diabetes, but the A1C is normal, but they still have obesity. I would titrate up the same, just like somebody who we're treating just for obesity. But it's kind of, I think this is where medicine is, it's science, but it's also an art, and there's not a lot of guidance with this right now.
Yeah.
Okay. Thank you.
20 seconds a week to lose 20% of your weight in a year with diet and exercise. That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.